So I will be recording this session for, educational purpose, and then I'll be sharing it through my YouTube channel. And as I mentioned earlier, that, I'm not an expert, and uh, whatever I'm sharing today is based on my own experience of teaching students for over a decade. And other than that, for my own experience, as far as the Canadian exams are concerned. So, QE1 or MCCQE1 qualifying exam one, whatever names we use to recognize this exam. This exam is not one size fits all. That is what my understanding is. It really depends that at what stage of your preparation you are, at what stage of your studies you are. So first, I will quickly, go through the goal of this session. So, since 2025, you all know that we now only have MCQ. CDMs have been removed from the section, and I will guide you that how you can structure your study plan. Some a few things that worked for me, and what can be your strategy to score well in this exam. So now the current format, as we all know, is that 230 MCQs are there and CDM part has been removed, and you have two sections with 115 questions each. Total duration has also reduced as compared to earlier, and main topics, they are your medicine, surgery, peds, obs, gynae, psychiatry, ethics, public health. Other than that, dermatology and all those things that I have discussed that later in the presentation as well. Now, what is the difficulty level of this exam? So, difficulty level of this exam is they are testing you on the level of a final year student or a first year resident. Somewhere there, maybe you are a first year resident or you are a final year student. So, in that setting, you are being tested for this exam. So that's why sometimes, the questions in the exam, you will not find them in any question bank. Whatever question banks you're doing, you might not find some of the questions in the exams in any of those question banks, because the questions are directed towards your reflex as a physician. So some of the questions, they might be very simple, like a simple definition. Like they will just give you a simple, straight definition, and you just have to answer that. And some questions will be a bit tricky, that will check your thought process, and what are your reflexes as a physician. So it all depends that at what stage of your preparation or your clinical studies you are. Now, people ask a lot of questions about resources. So, as far as the resources are concerned, there is no right or wrong in that. Whatever resource you are comfortable with. Toronto Notes, of course, everybody recommends it. Local people, look forward to study from it. People like it. But if it is not your piece of cake, if you find it difficult, I have friends who studied from first aid and mastered the boards MTB, and they did really well in the exam, because the medicine part is the same. Okay, the medicine part, whatever book you are comfortable with, whatever book you understand well, go with that resource. The part which will give you trouble, that would be your ethical part, and for that you have CMPA. So go to CMPA website, get yourself, accustomed to that. So this is something that you have to keep in mind. Hafiza Rasul, your camera is on. I just wanted to let you know if it's by mistake or otherwise. So, anyways, so you can use any books. A few people, they find it more easy if they use Toronto Notes. I personally studied from Toronto Notes, and the reason for that was because that was the only book that I could get from back home at that time. I was new in Canada. I just moved here, and a friend was coming over, and I found out that I need this book for the exam. So she could only carry a few books because of whatever the luggage she could carry. So that's why I only had that resource, and I started studying from that. So for me, my main resource was Toronto Notes, but it doesn't matter. I have friends who have studied first aid, mastered the boards, MTB. So whatever book, for example, if students are preparing for USMLE, They prefer studying from step 2 CK books and master the board and all those things. Now, as far as the question bank is involved, that which question bank to use and when, that is also something very tricky and important. Now, you have three resources in hand. Step 2 CK, you have ASQ Bank, and you have Canada Q Bank. If your exam is almost 6 months, there's a duration of 6 months between your preparation and exam, then I would suggest that go with Step 2 CK first. Go with the Step 2 CK question bank, complete that question bank study, because that will really make good foundation. You will be really good with your foundation if you go through the Step 2 CK scenarios. You go through the EOs and you read those exam questions. Are they similar to Step 2 CK? Not 100%. Some of the questions might have a little relevance to Step 2 CK questions, but not everything. Now, having said that, of course, Step 2 CK is a little bit more advanced as compared to the level at which this exam is testing us. So, if something, for example, cardiology in QE1, because it's a specialty, so cardiology is a little bit more in detail in Step 2 CK. So, even if for the first time you do it from Step 2 CK and then later on you switch to ASQ Bank, that would be more than enough. But at the same time, there are certain topics that I feel that are better in Step 2 CK. For example, dermatology. Dermatology, the visual presentation, the picture, they're very nice in Step 2 CK. So, dermatology is all about recognizing the rashes and their treatments and everything. So, personally, I did hematology and dermatology from Step 2 CK mainly. Psychiatry as well. It's very well written in Step 2 CK. So, if you have 6 months in your exam, I would suggest go with system wise, go with Step 2 CK, then like try to complete it within 3 months. Then near exam, for the next 1 month, go with Canada Q Bank. Um, do as many scenarios as you can from there. And then near the exam, complete your ASQ Bank. So this is how you can effectively use your time period. If you just start with ASQ Bank right away, I personally feel that sometimes you lack that reflex that you need as a physician to solve those questions. So, Step 2 CK in the beginning, and go with the 10 important chapters from Step 2 CK. You don't have to do, public health and biostats from Step 2 CK. It's very difficult in Step 2 CK, and this exam does not test you like that. So don't waste your time in doing that from Step 2 CK. For public health, for your this sorry, I'm entering someone in the meeting as well, side by side. So for them, for the core subjects like gynae obs, rheumatology, your GIT, hematology, dermatology, start with Step 2 CK, then move forward. Then after that, but one suggestion that I would like to give, that please don't switch to too many resources. If you keep on running in all directions, you will end up nowhere. Grab one book, stick to that book, memorize it, memorize the charts, memorize whatever key points are there in. Even if you're not studying from Toronto notes, the pearls which are on the sides and all the flow charts in Toronto notes, they are extremely important, because in the exam they can give you a question from any area of that flow chart. So this is very, very important that that what to study and where to study. It's not about studying hard only, it is about studying smartly as well. So that's why, because at the end of the exam, when you're near your exam, there are so many resources out there, and you will just mix up everything. So pick one resource and go ahead with that. Now, you have to tailor your study plan according to the place where you are. QE1 is not something like one size fits all, okay? You have to see that where you are as a physician. Either you are a fresh graduate, either you are an old graduate. Are you somebody who's returning to studies after a very long period of time? Are you someone who is appearing for the first time in the exam, a first time exam taker? Are you somebody who has failed the first attempt and now appearing for second or third time? So all of you need to have different, strategy to reach your goal. Now, for example, I will address each group separately. For example, if you are a new graduate, a fresh graduate, your strength is that you have that clinical knowledge. The theory part is very strong. You know the newest guidelines. You have worked in the wards, so you have those reflexes. So you have some updated medical knowledge. So if you are a fresh graduate, somebody who has recently finished medical school, and you are going ahead with the exam, in that case, I would suggest that on daily basis, you should have 70% of content reading and 30% of MCQs. That means that you should build upon those concepts that you studied in the medical college recently. Don't forget them. And along with that, start doing your MCQs on daily basis. Start doing your questions on daily basis. This will not let you forget whatever you have studied. Other than that, whatever you study, whatever the educational objective you find out, or a strong point or something to remember, write it down or make flashcards. At the end of the week, revise everything. For example, even if you have done 30 questions or 40 questions daily, by the end of the week, you will have almost a pool of, maybe 280 uh, educational points or something that you've done, and go through that every week. So that will help you retain that knowledge. In QE1, a lot of importance and a lot of focus is required on revising the content. You have to know stepwise management of everything. You have to know the stepwise approach to everything, and you have to memorize it again and again to make it a reflex. Now, I will give you an example. For example, you get a patient, and the scenario says that the patient had probably a subarachnoid hemorrhage, a patient coming with headache. The history is more or less relevant to, subarachnoid hemorrhage. And the patient presents to you. What will be the first investigation that you will do in that case? Any one of you can answer that question. Somebody coming with a headache, and you are suspecting subarachnoid hemorrhage. The question stem tells
CT
you
brain?
that,
Should we go for
sorry?
CT brain? CT brain?
Yes. Yes. And why are you doing that CT brain?
To look for any, to rule out any bleed or anything like.
Exactly. Okay, now let's suppose the same patient. Now the scenario tells you that this is the same patient. The patient had a worst headache of the life, had a subarachnoid hemorrhage, and then presented in the ER maybe 7 hours, 8 hours later. What are you going to do? What will be your first step in that case?
So that means CT was previously done, right? The question that you
No,
are
no,
asking, or CT was not done
no, no.
previously in this case.
Yeah, CT was not done. And patient comes after 7 to 8 hours.
I guess still we would go for CT. Mm-mm.
Yes. Very good. Why, and what will be the next step after CT?
Like, uh, uh, I think it depends. If there's any bleed, or like what is the cause, then later on, if it is needed, we can plan. I don't know, like mm,
Okay.
depend on
So
surgical procedure, like maybe plan for LP if needed, or I don't know.
yeah, so we go for LP because we are looking for xanthochromia, because the CT
Yeah.
would be clear. So after 7 to 8 hours, if the bleeding was is not if the history is suggestive of subarachnoid hemorrhage and the CT is clear, you don't find anything in the CT scan, the patient is presenting after a long time, then the next step is go for an LP just to rule out xanthochromia, so that you are sure that there is no bleeding. Now, in the exam, you can have this question scenario from any point. Like they can give you a patient with simple history of headache presenting with subarachnoid hemorrhage, and will ask you what is your next best step in this case. They can give you a scenario in which they will tell you that the CT was done, there was no bleeding in the CT. what would be your next best step, and the history is suggestive of subarachnoid hemorrhage. And they will give you a couple of options like CT, do an LP, or give the patient some Tylenol, do a questionnaire of migraine with the patient, give a neuro referral. So in the exam, they are testing you at different levels of care. They are testing you at different points just to see that what your approach would be in that case. So you should know each and everything stepwise. All That's why I'm emphasizing a lot on this, that all the charts which are in the Toronto notes, whether it's your head CT rule, whether it's your guidelines towards doing an X-ray chest or guidelines of doing pulmonary function tests, you should know stepwise that if we do PFTs, what happens, how do we label the patient as asthmatic or not asthmatic, what is the ratio and everything. So those things, I think, if you do it on daily basis, only then you can memorize them. Now, let's suppose you are a first time QE1 exam taker. You don't know how the exam looks like. So, of course, you are unsure about the exam, you don't have a previous trauma of failing your exam. So, in your case, if you follow a structured 12 to 14 weeks of, structured plan, and of course, if you have studied already, this 12 to 14 weeks would be your last run of the exam in which you will polish your skills, then in that case, stick to any two core resources. For example, if you are studying from Toronto Notes, in my case, I was studying from Toronto Notes, so I had the book with me. I used to do a set of 150 questions every day. 150 questions from different, this is, I'm talking about the last month of my exam, before my exam. So I used to sit for 3 hours, just like the way I will sit in the exam, and I would do a set of 150 questions, and I would randomly pick like 20 questions from here, 20 questions from there, from 4 or 5 units. I will do that in the exam mode, and then later on, I would correct, mark it, and whatever answers were wrong, I would go and read that back again in the evening. And at night, I used to study for like 2 to 3 hours with my study partner about CMPA on the CMPA website, because it was very dry, and both of us, we used to read it together, so that and do the questions together. So it's highly recommended that you train your brain that way, that you're sitting in the exam mode, no matter how much you study. If you have not trained your brain to sit for 3 hours at one place and do the questions just like the way you will do in exam, you will not be able to think, in the exam, and have those reflexes and have your stamina built. Now, if you are a repeat test taker, this is your second or third, attempt. You have already done the exam and you did not pass it for any reason. That means that you do have the knowledge, right? But you need some focus on the weak areas, and you have to practice more. So in this case, going again and restarting the book every day, it's not something that is going to help you again, because you'll make the same mistakes again. In your case, you have to do practice 80%. That is more than a new graduate. Practice almost 80% every day. That means do a set of 150 to 200 questions every day. Fix that time in the morning, the time at which you will have your exam actually. So, in that time, sit down, do that set of questions. Once you are done with that, whatever answers are wrong, go and read it again, and understand that which concept did you miss over there, which was the thing that you did not answer correctly. So you have to be your own teacher in this case, no matter how many classes you take, no matter how many. And I'm telling you from my personal experience, because I took some expensive courses. I was studying with IMGA as well. So, I was just thinking that maybe it's not enough. Maybe there's something wrong that I'm doing. But the only time that I could pass the exam was when I kept everything on one side and I started studying with the book and spending time with the book by myself. You have to be your own teacher, because what will happen in a big group class, somebody else is going to answer, okay, and you will rely on their answer. That is kind of a passive learning. You have to be an active learner. You should know that, okay, if I'm doing this step, why am I doing this at this stage, so that when in the exam they give you that scenario, you know that what is the best next step for your patient in that case. So this is how this this exam teaches you this strategy. So I would suggest that those of you who are appearing for the second or third time, you have to, maneuver your learning method a little bit, change it a little bit. Go with questions. Find any question bank, anything that is there, start with it. And near your exam, when you're about to have your exam, do ASQ bank in the end, because the questions are short and crisp. Before that, do step 2 CK. In my case, till the end, I was doing dermatology and psychiatry and rheumatology, and hematology from step 2 CK. And ASQ Bank, I did endocrinology, was very good in ASQ Bank. I liked it there. The flow sheets, the charts are very nice. So, and gynae obs as well. It's good over there. Now, I have made a list of important topics that I covered while studying from each unit. If you cannot do everything, at least you should do all these units, all these topics. So in cardiology, these are the few topics that I feel you get tested a lot on, especially STEMI, non-STEMI, very, very favorite topic of examiners. The reason is that they will ask you different stages. They can give you a patient who is just presenting with a chest pain. They can give you a patient just to see that if you are, aware of the PCI or not, that at what time duration are you supposed to refer the patient. So they will give you the distance, the timing between that at which time the patient had the chest pain and at which time did the patient appear to you. So what will be your management? They can give you a scenario in which you are working in a rural area where you don't have a cath lab nearby. So what are you going to do in that case? So you should know that, you will be going with thrombolytics. Which thrombolytics? Will you be ruling out the contraindication of thrombolysis before doing that or not? They might give you a small part of a patient's history, in which, just to make you think that, oh, will I give a thrombolytic to this patient or not? So this is how they are going to test you. Similarly, heart failure, hypertension. Hypertension is also very favorite of exam takers. Usually they are looking for the associations, that if you are aware that the drug, interactions, that which drug to give in a patient of hypertension. If a patient is coming with uncontrolled blood pressure, are you aware of the effect of NSAIDs on high blood pressure or not? Or are you aware of the causes, or what can be the reason, or what can be the next best step, or what investigation will you do to see the kidney function, that how well the kidney of this patient is doing. So a lot of questions around blood pressure are there. Similarly, arrhythmias, very very favorite topic. They always like ask something from the arrhythmias, either about the management, or maybe they can give you a patient who is coming to you with an arrhythmia and has a history of asthma as well. So which drug will you give now? So for arrhythmias, we all know that, oh, if it's an AFib, we will go with this regime, maybe a beta blocker and this and that. But if the patient is asthmatic, then beta blocker is a contraindication to that. So, you need to know the detail of everything, the context of everything. Similarly, pericarditis, cardiac tamponade, lipid management, very important. You should know the cutoffs, that what are the recommendations. Peripheral arterial disease, very very favorite topic of examiners. Similarly, endocarditis. A lot of questions are asked around these scenarios. Similarly, in respiratory, so respiratory, COPD, asthma, very, very favorite topic. You should know PFTs, how to interpret that. There's a flow chart in, Toronto notes that gives you the entire breakdown, that at what stage you call it COPD, when you call it emphysema, when you call it, asthma. So you should know all those things. Then pneumothorax, then, your pleural effusions, tuberculosis. For example, they can give you a case of pneumothorax, that the patient presents to you and is short of breath, and patient had maybe an accident, or maybe patient has Marfan's like feature, and he presents to you and he's short of breath. So what would be your next best step? Would it be an X-ray chest, or would it be a chest tube, or so you should know the ABC, that okay, I have to make the patient breathe first. So they might give you oxygen saturation, that oxygen saturation is dropping, and what would be the next best step. So somebody can think, oh, I might go for an X-ray first, but if the oxygen saturation is low, then of course you will be going with needle thoracotomy, as you will do that as a first step, and then later on you can see. But if the patient is not that short of breath, and the oxygen saturation is fine, so you can always do an X-ray chest. So the each and every detail of what to do at what stage, you are the one who has to know it. Don't rely on others, don't rely on your group studies and all those things to tell you. That you should know that what your next step is, and you should solve the questions by yourself. Similarly, sleep apnea, very important topic. They love it, and the questions around it. So similarly, lung cancer, you should know that which cancer is common in smokers, and which is common in non-smokers. So whenever it's a patient who is smoking, it's always your small cell lung carcinoma. If it's a non-smoker, then it's your adenocarcinoma, which is more common when it comes to your lung. Then the associations, for example, small cell lung carcinoma is associated with your diabetes insipidus, and your this what is the other association, the Lambert-Eaton syndrome. So the associations are very important, because they can give you some questions in that context. So when you will see the question, you will be like, oh, I have studied this somewhere, but the way they have asked it, it seems to be twisted, because they can ask from that question from any level of that flow chart. So very important to know. For example, in pulmonary, this embolism, a very, very favorite topic of examiners, very heavily tested everywhere. You should know your Wells score, Wells criteria, how to diagnose, how to take the best next step. They can give you a pregnant patient with suspected pulmonary embolism. You should know that what to do in a pregnant patient in that case, and what to do in a non-pregnant patient. So and then what is the criteria for giving antithrombolytics later on. What is given in pregnancy, for how long is it given in pregnancy, what is given not in pregnancy, and for how long is it given. So all those things you need to have a very good grip and grasp on that. Similarly, your gastro, you should know upper GI, lower GI. They can give you the entire flow chart, which is given for upper GI bleeding control in Toronto Notes or any other medicine books. That the patient comes to you, you did this. Now what will be your next step? What will you discharge the patient on? Something like that. So they can give you that question either from beginning or from the end. So you should know what to do in that case. Similar case for the complications, for example, these procedures like appendicitis and bowel obstruction, etc. What are the complications? The questions can be from complications of these diseases, complications of cirrhosis. Then when it comes to hepatitis, you should be aware of the serology, how to interpret the hepatitis B serology. You should know. They can give you a picture of the serology and ask you that, what will you do in this case for the patient? Will you vaccinate the patient, or does this information tells you that the patient is already vaccinated, and you don't need to do anything? So, a lot of things that you need to have your grip on. So know your hepatitis serology very well. A lot of questions are asked from there, from that section. Similarly, in endocrinology, diabetes, hypothyroidism, thyroid, a very, very favorite topic. You definitely get questions from thyroid, and know the associations that, okay, if if a patient has autoimmune thyroiditis like Hashimoto's, or any autoimmune, so what are the other associations with that? Celiac disease, type 1 diabetes. So if they can ask you questions around that, that a patient coming to you with celiac disease, what other investigations will you do in that patient? Or a patient coming to you with type 1 diabetes, what are the other associations, or what other tests you will do in this case? So you should know that if my patient is coming with a diagnosis of maybe Hashimoto's or type 1 diabetes, so I have to screen him for celiac disease as well, because all All of them have, those associations. Similarly, your pituitary disorders, osteoporosis, very, very important and favorite topic. Similarly, for electrolyte derangements, know about sodium, potassium, calcium, magnesium. These four are very, very important, especially sodium, potassium, calcium, magnesium, not that much, but sodium, potassium, and calcium very heavily tested. You should know how to manage hyperkalemia, hypokalemia, how to manage hypernatremia and hyponatremia. You can have all those things. What are the signs and symptoms of high calcium, and what are the associated things with that? For example, patient coming to you with a very high calcium and maybe some bony pains, etc. So know about your multiple myelomas and the associations of these high electrolytes. Similarly, in hematology, anemia is very important, very favorite topic of examiners. They can give you an elderly patient living alone on a tea and toast diet, having dementia. So you can think about, B12 deficiency, iron deficiency, because they are not eating well. Elderly patients do get that. Similarly, they can give you leukemias, lymphomas, then your coagulation disorders. In coagulation disorders, you should know that the important ones like von Willebrand disease, that is important, or hemophilias are important. Then DVT, transfusion reactions to some extent. Then neurology. A stroke, a very, very important topic. Why it is important? Because the management part, especially, you should know what to do in a stroke patient. If a patient is coming to you with an ischemic stroke, what is your golden time? At what time are you going to start the patient on thrombolytics? At what time are you going to discharge the patient on double anticoagulation? So know your time duration. In that case, they might give you a patient who's already taking one type of anticoagulation or antiplatelet, and then he comes to you with stroke, maybe later in the day, and now you have to discharge him. So you already have one antiplatelet that he's taking, so you will just add one more to the regime. So you will know that, okay, the patient is coming after 4.5 hours, and I have to give him double anti dual antiplatelet on discharge, but and anticoagulation on discharge. But at the same time, you will say, oh, that option is not in the options. But if you go back and read the question stem, they might have given you over there that he's already on these medications, and now what will you add more on his discharge list? They might give you something that is a contraindication, or maybe has a drug interaction. So be very, very careful, in knowing the steps of each and everything. Similarly, your headaches, your seizures, very important. The management of seizures is very important. You should know that what would be the first step if a patient presents to you with seizure or unconsciousness, whatever you're suspecting. So what are the bedside things that we can immediately do? For example, checking for blood sugar levels, calming down the patient, and whatever the protocol is there in the books, know that stepwise, very, very, very important. Similarly, in your neuropathies, know the patterns. What is the pattern of GBS? What is the pattern of peripheral neuropathy? What is the pattern of your multiple sclerosis? You should know all these patterns, because the level of weakness, the weakness starts from there and ends there. You should know those things, because if you don't know that, you will misdiagnose the patient. So you should know that what is the ascending pattern, what is the descending pattern of weakness. For example, patient coming to you and telling you that by the end of the day, I get so tired, I get slow, don't feel like eating, my eyelids droop down. So think about myasthenia gravis, because myasthenia gravis is something that triggers, by the end of the day, the patient feels tired, and it gets worse with activity. Similarly, GBS will have a recent viral infection, an ascending level of ascending pattern of weakness, and it will be bilateral. It won't be unilateral. So know your patterns very well. Similarly, if it's a multiple sclerosis patient, they can give you some eye symptoms, or even if eye symptoms are not there, it can be a migratory pattern. Like the patient will tell you that, oh, last year I had something in my hand, and this year I have something in my foot, some weakness in my foot. So it is a relapsing kind of a pattern. So know your patterns very well when it comes to neuropathies, because you will have just 1 minute in the exam to figure out. So know the keywords that, oh, this is bilateral, this is ascending, and the patient had a previous, maybe diarrhea or some viral infection. Oh, it's GBS. You won't have time to, think more than that about it. So know your patterns very, very well in neuropathies, because, in exam you will have a very long list of signs and symptoms. But if you know the exact pattern, that okay, this if for example they can give you a young patient, age of the patient is very important. So see, if it's a young patient, she wakes up one day and she says, I have some blurring of my vision, and then she complains about some unilateral weakness of a hand or a foot. This can be your MS, your multiple sclerosis. Maybe she's in the relapsing phase. So at that time, know what kind of treatment is available. What are you going to offer? So very important. Similarly, in Parkinson's, know your treatments, know your management plan for that. Okay, then next is psychiatry. Psychiatry is very, very important. You get a lot of questions from psychiatry. I will do a couple of videos on psychiatry, and I will share it with you guys. I know it is very overwhelming, but I will try to teach it in a simpler way to make your life easy. What is important is, and the thing that you have to do by yourself very thoroughly, is your psychiatric drugs. You should know your drugs inside out in psychiatry, their side effects, their key side effects, their interactions, what are the contraindications, because in the exam, they can ask you all those questions. You should know that if a patient develops, hypothyroidism due to lithium, what are you going to do in that case? Are you going to stop lithium, or if a patient develops tremors due to lithium, what are you going to do in that case? What is the level at which your patient will need dialysis if the patient develops lithium toxicity? So know these things very very religiously, that okay, this is a patient, the patient is having tremors, the patient was using lithium, the symptoms were well controlled, but the side effect is there. What are you going to do? No, I'm not going to stop lithium, I am going to add a beta blocker to this patient's regime, because and then I'll observe the patient over time. So although the CDM part has been removed from the exam, but they can ask you similar questions in your MCQs. So know that very well. Similarly, delirium, dementia, you should know the differences. You should know what to do in that case. Suicide risk assessment is also very important. Personality disorders, eating disorders, all these things are very important, and you should know how to manage these patients and how to diagnose that. For eating disorders, you should know what is your bulimia nervosa, what is your anorexia nervosa, the cutoff points, the BMIs at which you will label those patients. You need to know that inside out. Don't rely on others for that, because in the exam you have just 1 minute to make the decision, looking at the key points that, oh, this patient has this. Okay, this is laguno hair is given, irregular period is given, this is your anorexia nervosa. Sometimes you might not have the entire time to read the entire uh, the unit. Then pediatrics also very, very important. Pediatric jaundice, your failure to thrive is something very important. Vaccinations are very, very important. Not the schedule, because schedule can vary from province to province, but the vaccinations, what kind of vaccinations are allowed at what age group, and at the same time their contraindications. Each vaccine, you should know that which vaccine is contraindicated at what time, what are the side effects of those vaccinations, and not just pediatric vaccinations, but adult vaccinations as well. Pregnant ladies, the vaccinations for pregnant ladies as well. You should know that which vaccines we do not give in pregnant ladies, the live attenuated one, we don't give them. Which kind of flu vaccine do we give in the pregnant ladies? The nasal one only, otherwise the flu vaccine is contraindicated. So they can ask you a question that a female patient comes to you, she's pregnant and she's there for the flu vaccine, which one will you give? You should know that only the intranasal one can be given, but not the other one. The live attenuated, we are not giving that to them. And when to give it next, after the delivery, during the delivery. So know all those things. Similarly, pediatric infections, very, very important, and you should know them inside out. What is croup, what is bronchiolitis, all those things, because they will give you the typical, history in some cases, and in some cases they will ask you what the next step would be, what the management would be. They might just give you that, oh, give a scenario of croup and tell you that what the next step would be. We gave already racemic epinephrine was giving in the ER. What is the next step? So you should know the steroid is the next step. If they have even given steroid to the patient and the patient is going not breathing properly, then what the next step is? How are you going to secure the airway? Know these things very well. Similarly, for developmental milestones, you should know, what you should do in a patient. For example, if a patient comes to you and the parents come to you and tell you that the child is not talking, what is the first investigation are you going to do in that case? Anyone in the class can answer. If a child comes with speech delay, what would be your first step as a physician, or first question that you will ask?
About hearing, like
Yeah.
we would
Yes,
like
very
to
good.
evaluate the hearing problem with the child.
Yes, exactly. First, we will evaluate the hearing, that, when was there any hearing test done in the past or not. So yes, Dr. Noreen, thank you for answering that. So they are looking for these things, that are you thinking in that direction? Do you know what to do and what not to do, and how to take your investigations forward? Now, similarly, when it comes to your obs gynae, obs gynae is very, very important. Your prenatal screening, your gestational diabetes, they will ask you tons of questions from gestational diabetes. You should know when to do OGTT. You should know when to screen for that. You should know that if the oral glucose tolerance test is positive, what is next? You should know what is the follow-up of a pregnant patient after post-pregnancy, that she's done. She had gestational diabetes. Now, post pregnancy, how are you going to follow up? For how long are you going to do her HbA1c to see that she's not at the risk of developing diabetes? Similarly, for the next pregnancy, what are her chances to, get diabetes again? So you should know that. Similarly, your preeclampsia, eclampsia, know the management very well. Know that at what is your cutoff at. I've seen so many like some of students, my students who come to me and they tell me, oh, we live, you know answered that question as eclampsia, preeclampsia. And I was like, okay, at what week was the pregnancy? And oh, it was the first trimester. So how can it be, eclampsia, preeclampsia, if it's just your first week, or first trimester, sorry, of pregnancy? So know the cutoff ranges, that when do you label someone as preeclampsia or eclampsia, at what stage of pregnancy? What is the criteria? There should be, albumin in the urine, and what is the blood pressure range, and how you bring that down, and how you manage those patients, and what you do in the postpartum period with them. Similarly, ectopic pregnancy, ovarian tumors, very, very important. They can give you, the markers. There's a table in Toronto notes, a small table of ovarian tumors in which they have given everything. So just memorize that table. It will have everything. Similarly, contraception and infertility, two very important topics. If they can give you, they can ask you for indications of IUI, IVF. They can give you a scenario and ask you that what would be your, suggestion to this couple in this case. So know these things very well. Surgery, again, just do the important topics, trauma, ABC, the emergency chapter. The entire chapter is very, very important. You cannot miss anything from the chapter of emergency. So trauma, acute abdomen, the causes, bowel obstruction, ileus, hernias, burns, very important. You should know how to calculate the Parkland formula and how to resuscitate the patient. Fluids and electrolytes. Then 5 Ws of post-op fever. They are very much tested. Then surgical infections. They are very, very favorite of examiners. They can give you a post-surgical patient, and at different days of your surgery, like day 1, day 2, day 5. So you should know that, which infection can show at day 1, which infection can show at day 2, what can show at 3 or 4 or 5. Now here comes your rheumatology. So in rheumatology, what is important? The thing which is very important is that you should know the distribution of your joints, that which disease will start from which joint. For example, if they are giving you osteoarthritis, usually the thumb is involved first, so they might just give you this one keyword. That patient comes and she's saying that, I have pain in my thumb, in my right thumb or left thumb, and there is no bilateral joint involvement, other joints are all fine, and the rest of the history is very naive and normal. So you should know that which problem of which joint pain starts from which joint of the body, the big joints, the small joints, bilateral, unilateral. You should know all those things. Similarly in vasculitis, so vasculitis, all the vasculitis, they can ask you associations. You should know that what are the associations. Like for example, if the patient develops a saddle nose, which vasculitis is that, PNCA or CNCA? Know the differences between the two. Similarly, identify septic arthritis, learn to identify that, because that is a medical emergency. So you need to know, you have to save the joint, what to do in that case. Back pain is also very, very favorite topic. So rheumatology is a very small chapter. Know it very well, know the specific investigations. For example, if the patient is coming to you and SLE, you're suspecting SLE, you should know that you will be doing double stranded NTDS DNA, and whatever investigations are specific for that, you should know them by heart, because they might give you a few in the exams and give you the rest in the options, and you have to choose that one from there. Now, in dermatology is, I think, entire dermatology is important. Do it from, like, to be honest, I did not study this chapter from Toronto Notes at all. It was very long, a long chapter, and very boring as well. I couldn't, keep on memorizing that, oh, this is the papule, and this is a macule, and this is that, and this is this. So what I did was I did entire dermatology only from step 2 CK, and just memorize it from there. Even if you don't do it from the book, that's fine. Step 2 CK has more than enough knowledge for dermatology and the questions related to that. So do it from there.
Uh,
Next is your
Excuse me, I
infectious
have a
disease.
question.
Yes, please go ahead.
Okay, so like you're talking about you did dermatology part from the step to CK. So was it the first aid or the UWorld step to CK?
No, no, you world.
Yeah, you are talking about the UWorld, right? So same goes like you did dermatology and hematology. So like rheumatology. So can we do all these subjects like infectious disease, rheumatology, dermatology, and ophthalmology, ENT? So can we cover all these topics, high-yield topics like you have mentioned from the step to CK UWorld?
I did it from there. I did ophthalmology, ENT, this hematology, most of the hematology, infectious diseases, and this dermatology. I just did that from U World, Step 2 CK U World. That's it. Like the U World, the question bank. I did the questions, I read the scenarios, I did it from there because it was too long in Toronto notes. So I did not do those chapters, ophthalmology and all those things. I did not touch Toronto notes for that. I just did it from there, and it was more than enough to do the scenarios.
Okay,
So my
thank
suggestion
you.
would be that, yeah, because you should know the topics very well, and you should be able to remember them. So for me,
Mm-hmm.
step 2 CK was working. I was able to memorize it from there, and then I was able to apply my knowledge to other question banks. I was doing, I was studying with AIMCA, so whatever question banks they used to have, I was able to solve it with the help of step 2 CK, the U World. So I would suggest that if you have time, if you want to go through everything, that's your choice. But for me, I just did gynae obs, emergency, family medicine, pediatrics to some extent, not everything, just a few topics. Those were the things that and psychiatry, yes, I did that from Toronto notes. So emergency, family, yeah, gynae obs, these things. But ear, ENT, all these things, I did them from U World. Dermatology I just did from U World. Very nice pictures and very nice explanations, and it covers everything. Like there is nothing that is left, which is in the chapter and it's not there. So even if you just do it from there and keep on revising it from there, know the key points and the treatments, I think you should be fine. Now comes public health and epidemiology. So I'll be honest here, this topic is not my favorite at all. No matter how much I study, I am never able to memorize and master it. So what I did for the exam was that I just did this much. Sensitivity, I just memorized the definitions, sensitivity, specificity, PPV, NPV, positive predictive value, negative predictive value, odds ratio, relative risk. I just memorized how to calculate all that. I studied about the screening programs. Of course, that is very important. Screening programs are extremely important. Types of studies, you should know them because they can give you in the exam, they can give you some definitions and they can ask you what type of study is this. So you should know that. Biases and outbreak management and vaccination principles. So this is the only thing that I did from this chapter. Other than, and I just did it from ASQ Bank. I did not do it from UWorld because it was very, very dry and time taking from UWorld. So I did not waste my time on that. Because I know that no matter how much time I spend on this topic, I am never able to memorize it. So this is the only thing that I did for my exam in public health and epidemiology. Then comes your indigenous health. So indigenous health, what I did was that for indigenous health, whatever I could find online, because when I gave the exam at that time, it was very newly started. Indigenous health was very, very new and they introduced it. So I had a few questions related to indigenous health, but I would suggest that you should like know these headings like social determinants, residential schools and historical trauma, trauma informed care, cultural safety, barriers to accessing care, indigenous maternal health, suicide prevention in the community, and consent and communication scenarios. So if you just write these topics on YouTube, you can find some videos. Just have a look at them so that you know their hierarchy system and how things work in their capacity and what you do about them. So this is how I did this part during my exam. Then next is your ethics and professionalism. So this is a very heavily tested section. Those of you who have already done NACOSCI, they will be halfway. They are halfway already done with ethics and professionalism. If you have given NACOSCI, then of course you know ethics is a big component which is tested there, and I teach my students during my course as well the ethical dilemmas and you know how to deal with the practical problems. So in the exam, you will only have those scenarios. For ethics, I would say that there's a small chapter in Toronto Notes. Read that. You should know what a coroner is. You should know what is fitness to drive. What are the different um, offenses at which you have to inform the Ministry of Transportation. What are the diseases in which you have to inform them. And similarly, the CMPA website, go through that website. They have a podcast as well now. You can listen to it while driving or while working. And just go through the CMPA, read it every night, do the questions which are available with it, and just make it a habit of going through that and doing those scenarios. Because in the exam, they will test you on ethical scenarios. A few questions, in fact, a big component of questions is there from the ethics. And so know ethics very well. The Canadian ethics are different from the British and the American ethics. Slightly, there are a few things here and there which are different. So you should know that. If you have given any British exams earlier or you're giving step two, like steps, of course you will not know the details which are here. For example, in Canadian law, there is no age of maturity, the 13 and 14 years old can make their decisions. So, but in the US law, it's different. In British, it is different. So you should know the age of consent for when it comes to children in Canada and other ethical aspects as well. So know your ethics really well. In the end, I have just compiled everything. Family medicine chapter is in Toronto Notes. You have to do it from there. It's very important. Each and everything of family medicine is important. You should know that chapter inside out. So I have divided it into different sections. So you should know preventive care and screening. So know your screenings really well. You should know each and every screening, like smoking, a PAP test, the cervical cancer screening, lung cancer screening, diabetes screening, lipid screening, statins, all the osteoporosis. They are very important and they are tested on exam. At least one or two of them are always tested. They can give you a scenario that a woman comes to you, she had a PAP and she had maybe this maybe LSIL, or maybe she had we got a blood on the slide and we were not able to see that what kind of PAP cells were there. So what are we going to do next in this case? How are we going to screen her again? So know that very well, that when are you going to repeat the PAP test? What are you going to do in that case? What vaccinations will you offer her? How will you be checking the HPV status and all those things? Similarly, for lung cancer, you should know that what is the pack year of smoking history that the patient needs to have in order to have the CT, the low dose CT chest for lung cancer screening. And you should know the complete word that it is a low dose chest CT, because they can give you multiple options at CT chest, low dose CT chest, and when it is done and how frequently is it done. You should know that, what is the frequency and when it is not done. Similarly, breast cancer screening. So, screenings are very, very important. Know them really well. Then chronic diseases, of course, you will be studying them in other chapters as well, and it will just be a repetition here. Then know about women's health, mental health and family medicine, depression, anxiety. You will be doing everything in psychiatry. So if you have done this well in psychiatry, you will be able to tackle it here. Then know the names of the counseling skills only. Then pediatrics, geriatrics. Geriatrics is very important, as I mentioned earlier as well. They ask a lot of questions from geriatrics in the exam. Similarly, dermatology, MSK, office emergencies, office procedures, and indigenous health. So these are some of the family medicine topics which are very important and you should know them. So this yeah, winds up my presentation for today. So this is just a guidance on how I prepared for the exam. If you have any questions, let me know. I'll be more than happy to answer that. Yes,
I have a
please.
question.
Yeah. Yes, go ahead, please, Fariba.
Uh,
Okay. So,
Hi,
okay.
hi, Dr. Sana. How are you?
I'm good, thank
Just
you, Fariba. How are you?
thank you for asking. Yeah, I'm good, as well. Would you please send this actually the workshop, everything, especially because it's included the high topic. Could you please
Mhm.
send it to the Telegram then, or no? Is it
Yeah,
possible?
that's not a problem. I will upload this on the YouTube channel as well. So
Oh,
I can share the link over there as well, or if you want, I can just send you these slides as well. Not a problem. I can share on
okay.
my main. Yeah.
Thank you. Thank you so much. Take care. Take care, Dr. Sana. Thank you.
I have a
You're
question
welcome.
as well.
Yes, please go ahead.
Okay, so my question is, I know this question might not have a specific answer, but like what is the like standard preparation time for this exam? Like I know it varies, like it depends on your background knowledge and stuff, but it's still
Mhm.
like right now I'm planning for April or May session. So,
Mhm.
and I have started my preparation like a month back. So, do you think like 5 to 6 months is enough for this preparation? And like keeping in mind that I have also given my SAP 2 CK exam, but it was like 2, 3 years back. So like
Mhm.
my knowledge is not that fresh for sure, but I am familiar with all these Q banks and stuff. So like, what do you suggest? Like, how many hours daily like should we do, and like, is there any standard like timeline we need to follow?
So in my what my experience is this, that if you have given an exam already, like you did step 2 CK, and after that I don't know if you were working or not working, but if you had
Yeah,
some
I
clinical
was working.
experience,
Yeah,
you were
I was working, and I was very in touch with like I was working.
I think you can easily go ahead in April, May for with the exam, provided that you do get like 2 to 3 months of dedicated study time in the end. So because for me, when I was giving my exams, so I in the end I took 3 months off from my work, and I told them that I have to give the exam now. So in those 3 months, then I was just focused on my preparation. So what I used to do was I used to do question back for 3 hours in the morning, 9 to 12 every day. And when I gave the exam, then CDM was also a part of the exam. So I had a
Oh,
longer exam to do.
yeah.
So that's why I used to study for 3 hours in the morning. Then after getting my kids from school and giving them lunch and everything, then I used to study for 2 hours for with the book, the mistakes that I had made in the morning. I would review them. And then at night, after dinner and putting them to bed, at night from 9 to 12, I used to study with my study partner. We used to go and review one chapter together, or we would do CMPA reading for half an hour or an hour. So in the end, like last month, I would suggest that you should take some time off and dedicate full time to the exam if you can do that. Otherwise, if you have given the exam and you were in touch with a few things here and there, then I think you should be exam ready by April and May. You don't need that much time. 6 months are required for somebody um, who has been away from studies for a couple of months. But if somebody is taking a very fresh start, like a new graduate, sorry, an old graduate who has a gap, for them, I feel that 7, 8 to 9 months are required. So,
Yeah,
so
okay.
yeah, it's
Um,
better that in your case, I think you can easily give it in April and May
yeah, and
if you
also
are
I just
dedicated.
resigned, so right now I'm not even working. So like I have these 5, 6 months for preparation
Yeah.
only. So yeah, I'm not working right now. So yeah, I can give
Yeah, so just
dedicated
give this
time.
dedicated, yeah, that would be great, because give this dedicated time to the exam, know everything inside out, and the important topics. Exam is not like, don't go for very complex things or don't go for multiple resources. Just grab one thing and study from that. For example, in my case, I had Toronto notes. I did not go for any other resource because I did not have the time. I took some expensive courses as well, but to be honest, I couldn't even read the slides of those courses. The reason was
Yeah.
that there was no time, and I had already been studying with Toronto Notes for the past 1 or 2 years. So I said, no, I'll just stick to this resource, whatever is here. And I had the book from 2018. It was not even the new book. No, I
Oh,
cannot
okay.
switch my resource because
Yeah.
I have a visual memory, so I used to know the page of my book, that okay, on this page I've written this, on this page this is mentioned. So according to me, because before that, I have, by the way, I have given QE1 twice. Okay, so I did not
Okay.
pass it in my, yeah, first attempt. At that time, I was a bit in a hurry to give the exam because I was expecting. So I said, okay, before the baby, I should get rid of the exam. And I did not. I underestimated the exam. It was 7 hours long. I couldn't sit for that long. I was in my last trimester. I didn't pass it. So when I gave it again, I just did it from the same resources. So, any other questions?
Hi, Dr. Sana. This is Noreen speaking. Hi.
Yes, Noreen.
Yeah, I'm doing. Hello.
Go ahead. Hello, yeah,
Yeah.
I can hear you, Noreen.
Yeah, like I said, like this is gonna be my third attempt. First attempt I just gave, I just have read my questions, like all the ASQ bank. Just the ASQ bank I did on my first attempt. No notes, nothing. And second attempt I gave with U World notes. U World notes and ASQ bank I did. So now this is going to be my third attempt. So like am I supposed to again go through like the Toronto notes or just go with the U World notes? Like what?
So, so Noreen, say that, since this is a third attempt and you have already studied a lot, as I mentioned earlier, I don't know at which part of the presentation you joined in, but I mentioned earlier as well that if you are a second or
Yeah.
third time exam taker,
Mhm.
uh,
Just
focus
do the
on
that.
yeah, focus on MCQs. Do your MCQs in the morning. Whatever you feel is an error or you did wrong, then repeat, then go to your book again at night, open Toronto Notes or First Aid or whatever book you've studied, and then memorize it from that. So strengthen on those areas that you feel that, you're missing on.
Mm-hmm.
And yeah, so because if you will keep on repeating, just reading Toronto Notes will not take you anywhere. I'm telling you honestly, like you will just forget it. On the exam day, you won't even remember that what I read in the book. So unless you have not done the questions critically by yourself, so that is my suggestion that do question banks in the morning, then revise it from the book in the evening. And
Okay.
if yeah, if you want, I can if I have some time, maybe next week, I can have a one-to-one session with you, and you can, if you're comfortable, I can have a look at your statement of results, and I can help you and see that which part you were,
Mhm.
struggling with, diagnosis or management. So if you feel comfortable, just drop me a message, and I'll be more than happy to help
Yeah,
you.
sure, sure. Thank you so much, Dr. Sana. And also, I wanted to know, like, last 7 days of the exam, like, am I supposed to do the theory part or just the MCQs I need to revise? The last 7 days of the exam.
Last 2 days of the exam, don't study. At least one day.
No
Last
theory.
one day, don't study anything. So make it last. It's because it's a big exam. You need your mind to relax, and whatever you will study at the last moment, it will stick to your mind, and then it will,
No.
affect your judgment. So last 6 days of the exam, just do your MCQs, repeat the guidelines of, the screenings, vaccinations. These things you can revise in the end,
Okay, okay.
but just do the
Okay,
questions.
okay, Dr. Sana. That's it. Thank you so much. It was a very good section.
You're welcome, my dear. Any other question? No other questions? Okay, so thank you everyone who was able to join. And if you have any questions, you can always drop me a message on the Telegram, and I'll be more than happy to help you guys. I will try to, just one second.